Well, thank you, and congratulations again to all of our bursary winners, and thank you to the sponsors of those as well. So, as I mentioned just before the break, last minute change to the programme. Unfortunately, Professor Michaela Carver is not able to join us, but we've got an excellent alternative in the form of Professor Gordon Cook. Gordon, you all know, is a Professor of Haematology in Leeds, and actually it's interesting hearing Jamie talk about his early work when he was involved in with Tim McAwain and Ray Powell and Hyder's Malfan. Gordon, of course, some of his early work was really using DNA damaging agents in terms of ZDEX, and ZDEX is that still occasionally comes once or twice a year. Obviously he's done huge amounts since then, far too much to summarise in the 30 seconds, but you all know Chief Investigator for the myeloma 10 study, which is really embedded second autologous transplant in myeloma, not just in the UK but also internationally, and then more recently in terms of myeloma 14 fitness, which really is the theme of his presentation today, which is really your own perspective, Gordon's own perspective on treating frail, elderly myeloma patients. And we'll have a few minutes at the end for a panel discussion with some other colleagues joining us on the stage as well. So welcome, Gordon. Thank you very much for stepping in at such short notice.
Thanks very much, Matt. And I've already apologised for my appearance. So my second apology is for those who have made an effort to come here to hear Professor Cable give his presentation. He is an excellent speaker. And I feel like the sub who's been brought off the bench because Ronaldo's pulled up with some muscle cramp. So for that, I apologise. I would like to say, Michele, if you've joined online, I hope you have a speedy recovery. He is a superstar in myeloma. Right, so instead you've got me. So what am I going to talk about? I'm going to talk about frailty. First off, these are my disclosures. And you may or may not be aware, but we have a frailty working group under the UKMRA, which is a truly multidisciplinary group, and we're looking to try and devise new clinical trials and bring in an ethos of oncogeriatrics into myeloma. And in fact, Sally Moore, who asked the question at the end of the last speaker, Sally has generated an excellent, almost final draft best practice paper on how we look at oncogeriatrics. That I'm not going to touch on. I'm briefly going to talk about the unmet need. I'm then going to talk about how we define and how we could define that population who are at risk. And we're talking about frailty and vulnerability in myeloma patients. And then I'm going to talk through a bit about how we manage patients and maybe some ideas for going on in the future. So deal with the unmet need. The population is getting older, and it's estimated that over 80s is going to quadruple over the course of the next few years till 2050, the middle of this century. And it comes as no surprise when you look at this WHO map. It is a global issue, but it's localized in the more developed countries, as you can see on here. But of course, with age comes its problems. And I'm afraid for anybody over the age of 40 in here, I'm afraid you've peaked. If you look at this here, you see that you start to decline, okay? So you will lose 1 to 2% of your muscle mass as a matter of getting older from your early 40s. And that's with people looking after their bodies. But when you start to add in illnesses, then this line starts to accelerate. And when you look at this, what it shows you, accelerated aging takes you into physical frailty, sarcopenia, loss of your independence and disability. And that is a matter of how we look upon society. So when you get a disease like myeloma, it has subsequent impacts on this. And it brings a bit of a dilemma, because depending on where you are with myeloma, whether you are fit, less fit, or you're frail, your treatment goals may be different. You may look for quality over quantity, and that does change how you manage patients. And as Neil's already mentioned, one size does not fit all. This is some data from the Connect registry showing the overall survivorships for people under the age of 65, going through the ages to the older population. You can see the clear unmet need in that context. This is actually data not from Michele Cavo's team in Bologna. This is actually from the Torino group, Sarah Bringan's work. And what you can see here is deaths within this trial from toxicity or other cause of death. But what Sarah did was broke it down into under and over 80s. And you can see the under 80s here solid lines compared to the over 80s and the dotted lines. They are more prone to toxicity, and toxicity resulting in mortality as much as they are anything else. This is data from myeloma 11, and Charlotte has presented and published this data. And what this is looking at is the relative contribution to PFS and OS from 3 key well-known factors. Green, cytogenetic risk, red, international staging system, and blue is performance status. And the point of this is, as you look across the age ranges, the blue bar becomes more important in driving change in PFS and OS. So, how do we define risk? Well, myeloma was a bit slow to really come to the idea of bringing in geriatric assessment-based clinical scorings. But one of the issues is that in the context what I showed earlier, with the declining curve, as we get older, there's a biological reason why we start to lose our physicality and independence. It's the accumulation of senescent cells. And they give rise to the inflammation, the production of inflammatory markers and driving immune senescence. And this prevails with the evolution of chronic disease, metabolic disorders, cardiovascular diseases, and cancer. And in the context of myeloma, that process can be accelerated by the end organ damage, the immune dysfunction associated with myeloma, but also treatment. And when you look at that, potentially, if you take away the disease overlay, you might improve people's performance, but as you continue treatment, you may then subsequently deteriorate people's performance as a consequence of toxicity. So how do we measure? Well, far left column here is Antonio Palumbo's IMWG frailty score, which is 9 years old now. And this was the first time that as a specialty we had come to the idea of geriatric assessments. The modified IMWG frailty score was designed particularly to be applied retrospectively. And this is because it takes out ADL and IDL, which you cannot calculate retrospectively. And therefore you can apply this to clinical trials. I did notice at the IMS meeting last month that this has now been called the IFM frailty score. Now, the politics behind it you don't want to know about, but anyway, it was created by Thierry Facon to interrogate the first trial, and therefore it's used more and more. There are differences in interpretation of the data between these two, but we won't get into that today. And there's other ones like the UKMRA myeloma risk profile, which is not a frailty score as such, it's more of a vulnerability score. So I want to just give you heads up on 2 patients to draw some issues of controversies around this. Let's start with this. John, an 80-year-old, presents with his myeloma, kind of standard appearance, multiple lithic bone lesions, but he has no comorbidities. He has a significantly active sporting life, and he is the full-time carer for his wife. But under IMS frailty score, he is frail because he's 80. Let's look at Mary. Mary is under 80. She's got typical myeloma presentation again, but she has multiple comorbidities, and her independence is limited. And under myeloma frailty score, she is frail. The problem comes with how do we treat those 2 individuals if we just base them entirely on frailty scoring? Do we treat them the same? Will they tolerate treatment the same? What would you do with the treatment in relation to their frailty going forward? Is there a risk we will under or overdose these individuals? So, this is a month of controversies. I couldn't resist this. But of course, that's really what we all know, don't we? So, the controversies. Frailty scores are blunt tools, okay? They're useful, but they are blunt. They've also only ever been proven to be prognostic, not predictive. What that means is you can't actually use them to drive your treatment decision making. Are they dynamic? And I've already mentioned, the idea is that you may end up under-treating people if you use the frailty scores. And then lastly, can physicality be modified? And we'll touch on this at each of the stages going through the next 20 minutes or so. So this is the only trial worldwide that's looking to develop the notion that the IMWG frailty score is a predictive biomarker. Trial closed to recruitment earlier this year. We have actually got 2 orals at ASH this year, one about the health economic impact of frailty, but the main primary endpoint abstract for those going to ASH is on Sunday afternoon at 4:30. Shameless plug, but come along and support us if you can. Anyway, because of ASH embargo, you're not getting any of this data today, but hopefully I'll give it to you next time. But one of the things I can show you is this Sankey plot looks at the changes in the frailty score, IMWG frailty score, every 2 cycles. And if you concentrate on the red bar, you can see that some frail patients continue to be frail throughout. But you also can see some frail patients becoming unfit or even becoming fit as early as 2 cycles. This is IRD. It's not the most potent regimens we all know because DRD is in that space. But you can modify frailty by modifying disease as an early stage. So that's about the dynamism. What about, can we improve on the frailty score? This is work that Sonja Zwiegman from Amsterdam did and presented by Claudia Steger at ASH a couple of years ago and then published in Leukemia. And what Sonja did was she, first of all, plotted out these graphs. These are the IMS frailty score absolute data. Okay, so you've got having 1 point, 2 points, 3, 4, 5. Okay, now to be frail, you need 2 points. But what Sonja clearly demonstrated is that 2 and 1 run together. So she said, well, why don't we actually change the frailty score and make it 3+? So this is the original IMWG frailty score using 2 as a cutoff. But when you make it 3+, there is much clearer separation. So perhaps we need to revise our definition of the frailty score. I took a real-world data set that we'd done in the sort of post-COVID area and did exactly that. Did 2+ versus 3+, and there's 2+ and there's 3+, so you can see them separate. The other thing I did was I took everybody who was scored IMWG frailty, i.e. 2+, and then looked at what their MRP was. And if they were MRP high risk, they followed the red track. If they're MRP non-high risk, they follow the green track. And this is the idea of maybe dialing in a bit on the ultra-frail population, the group of patients that we cannot treat the same way without either modifying their physicality or expecting poorer outcomes. Biomarkers of frailty. I'm going to touch on this in the next few slides. These are not necessarily to replace the frailty score, but perhaps to add to the frailty score to try and dial into a bit more of a personalised approach. Immune profiling, body composition, cognitive assessments, and we've got an issue, not issue, but an interest in medtech-driven movement science. Bit of immunology. As we start off in life, we have a very diverse immune repertoire, particularly because of a highly active thymus. And as we go through life, we get thymic involution, we get proliferation pressures from human viruses such as CMV. As a consequence, we then get clonal diversity reductions. Second thing is that we also have drivers towards developing immune senescent cells. So they do exist in the younger person, they just become a much bigger part of the immune repertoire in the older person. It's an area that we're particularly interested in the lab. So we have done quite a lot of clonal diversity limitation work. Johnny Carmichael and my PhD student that did this, and there is definitely not only an age effect, which is evident when you would expect, but also a myeloma overlay. Francis Seymour has been leading the immune senescence, immune exhaustion work in the lab, as well as the immunometabolism work looking at mitochondrial dysfunction. And also there's something that's just appeared that is this age and sex dimorphism. So the effects that we see in the immune landscape are more marked in older men than they are in older women for reasons that are not quite so clear. Possibly related to hormonal drivers, but given the age population, it's kind of difficult to work out. But this is a phenomenon that's been recently reported in the immunology literature. Epi-aging, this is not something that we do in the lab, but this is an area that Charlotte Pollin's looking to develop. And this is about looking for methylated CpG islands and looking for the difference between epigenetic age over chronological age. And that can give you a better measure of somebody's physicality and somebody's long-term outcome. And this is some interesting work. This is a slide I borrowed from Ashley Roscoe. And this basically shows that you can actually change the epigenetic aging through physical activity, which is something we'll return to towards the end. One of the things that my group's interested in is secondary purposing of diagnostic imaging to be able to actually segmentate the CT scans. You can also do this to a degree with MRI scans, but we can actually do things like cardiovascular risk because of calibrating the aortic calcification levels. Look at adiposity distribution, mainly look at sarcopenia. In myeloma, we're not particularly interested in the liver density, but it's an avenue of what we do in solid cancers. This is actually from my AI PhD student who's looking at generating 3D models. This is actually visceral adipose tissue. Excuse me. This is subcutaneous adipose tissue, and the red one is the actual muscle of abdominal walls. And this is about, I've got a clinical PhD student who's doing this. I say the AI PhD student's doing this, and this is an idea of trying to develop body composition and how it relates to vulnerability to treatment, toxicities, and outcomes. There's a little bit of evidence showing this is just 2D sarcopenic measurements where you take a cut through L3 and you measure muscle volumes. And basically what you can see is the absence of sarcopenia, the blue line, patients have got better survivorship than those with sarcopenia. So it's a surrogate of treatment-related toxicities. Cognitive assessments, this is a very new area for our group to get into, and particularly neurocognitive imaging. So I don't actually have any data as yet to show, though we're just about to pull together a pilot study as a data collection and send to publication. However, again, this is a slide that I got from Tanya Wilds, and this is actually about hematological cancers, and it's looking about, this is the clock in the box test, and you can see that's a normal and that's an impaired cognitive patient. And what this study was able to show in over 300 patients, that those with cognitive impairment have less good survivorship outcomes. So again, this may be a way of dialing into the functionality behind things. But of course, you kind of can't do this on its own. You need to bring it together. So this is going to be something that's important as we bring some or all of these parameters together and using AI develop clinical prediction modelling, and that might be the best way forward. So, managing risk. How do we manage patients going forward? As already been mentioned this morning, DRD is a standard of care in non-transplant eligible patients. You've seen that this is Sajid Kumar's update on the Maya study data with very impressive PFS and OS, and we now have that in our clinical armamentarium on the NHS. It came into being October of last year, and by March, 86% of transplant non-eligible patients in England received DRD. So clearly a game changer. Thierry, myself and Sonia then applied Thierry's modified frailty and was able to demonstrate that green is non-frail and blue is frail, that advantage of DRD in even frail patients is well preserved, albeit at a lesser degree than what it is in the non-frail patients. And when you look at the late phase trials in the transplant eligible space, that there was no frailty limit on these trials in the past, the first trial, the Maya trial, and the Alcyone. But going forward, there's a whole number of trials where there is a bit of a frailty limit. So negating patients who are deemed to be frail going into the trials, or specifically targeting those patients. So the landscape is definitely changing going forward. There's some new data on the block is the IMROS data, which is ISA VRD versus VRD. I only show the trial schedule just to point out that it was twice a week Velcade, which we don't do in our clinical practice for anybody, let alone an older patient. But anyway, I point that out. So when you look at the characteristics of this trial, I would like to say is that disease burden-wise, relatively few people had stage 3 disease. Nobody was over 80 because that was a limit. And when you look at ECOG, very few people were ECOG 2. So these are good players, and that's something we need to be mindful of when interpreting this in light of our clinical practice. Nonetheless, pretty impressive depths of response, including MRD negativity. And when you look at the PFS analysis, I mean, out at 60 months, it's nowhere near the 50% marker. So this is pretty impressive data. Is there a price to pay? Of course there is. And particularly infections were much higher in this VRD going forward. I just highlighted this second primary malignancies. Bear in mind the group of patients that this is involving. There is still that second primary malignancy signal, as you would expect. I mean, there is a lenalidomide backbone here, but there is a bit of an uplift, or even what we would expect with lenalidomide alone. So what is not published is this data, and I do have permission to show this. And this is the same as what Thierry and I and Sonia did with the Maya data, did with the IMROS data. And basically having frail and non-frail groups represented here as the ISA VRD versus VRD. And you can see significant differences for both non-frail and frail patients in this setting. So interesting. Bear in mind that none of these frail people were because they were 80 plus, because remember, it was capped. So these are people who are frail based on a number of other features, which is interesting. There are a couple of other trials in this space, Cepheus and the benefit study, which is led by Xavier Leleu. And the benefit studies actually mirrors quite nicely the IMROS study in terms of being ISA VRD going forward, without the caps that were put on for the IMROS study. Xavier gave me this slide. This is sort of up to date. It's very early. It's only 30 months, so the curves are not separating overlapping confidence intervals, but it's only 30 months. But when you look at the response rates, it's pretty impressive, including MRD negativity. So definitely space to watch. So this is what we currently think of in terms of our older patients. Because of the Maya data, DRD, and I've mentioned the level of uptake in England. But how do we move forward with IMROS benefit, Cepheus? The IFM 2017 is a steroid-free regimen. As a study, it closed 2022, but Salman Mani tells me he's not going to be able to report anything, probably not until this time next year. So we do await this. The depth of responses, which is an early readout, looks quite promising. But maybe our fit population are the ones who are going to benefit from that 4-drug regimen going forward. And that's the population that are the should be autographed, should be not autographed, the grey zone, so to speak. And I suspect that this kind of treatment will actually challenge that. So in the last few bits, I'm just going to talk about performance enhancement. And I put this slide in for the benefit of Jamie, who is, as I mentioned earlier, an avid cyclist. No, I'm suggesting for a minute, Jamie, that you partake of performance enhancement. But of course, this guy gets a bad rep. We all know who that is. It's Lance Armstrong. But this guy's fascinating. This guy used to take he won the Tour de France 6 times. And he would dope up with cocaine in his eyes, chloroform in his gums, taking strychnine for muscle cramps, and caffeine. Now, that's a bucket load of cheating, but there we go. He was still a remarkable cyclist. Very sad end to his life. He was shot by his girlfriend using the same gun that his wife had committed suicide with. There you go. I'm a fountain of useless knowledge. Anyway, moving on. I've already mentioned senescent cells and how the fact this is a normal, so a cell when it's under stress goes to sleep, inverted commas, and then naturally it will be eliminated and then you get repair. That is the physiological way tissues deal with the insult. In cancer, what happens is there is no senescence. That's what senescence is there to try and stop this transformation. As a consequence, there's rapid multiplication and you don't get them eliminated and you develop cancer. Well, in ageing, what happens, these senescent cells are not eliminated, and it drives the physical deterioration that I've already mentioned. This is important because senolytic therapy may well be a performance enhancement that could alter how we do things. And this slide puts together some ideas, not just about senolytic therapy, but ways of trying to improve. We know that calorific control in the older person is important, protein loading of diet, etc. And we have an academic dietitian on a frailty group because it's really important. Exercise is really, really important, particularly after the diagnosis of cancer and cancer treatment. And again, we have two academic physios on our frailty group because that's something we need to investigate going forward with. Senolytics, we're talking about repurposing drugs here. Dasatinib, IL-6 blockade, rapamycin, metformin, and what these do is in different ways alter the senescent cells' production of inflammatory mediators. Mitochondrial dysfunction is an area that we're particularly interested in our lab, and you can modify that with nicotinamide riboside, not just in the lab, but also in the person. It's been published in Healthy Octogenarians, and we're keen to get this into myeloma trial. The beauty is that's not a drug. It's a dietary supplement, so we get around a lot of rules. And then there's the issue, and I haven't got time to get into this, but happy to discuss it if anybody wants. It's the whole issue about what CD38 does to the microenvironment. Its ectoenzyme capability is to deplete NAD, and NAD is a main substance that mitochondria need. So in actual fact, giving daratumumab, isatuximab, may well improve the tumour microenvironment NAD and improve the functionality of cells. So with that in mind, how do we move forward? We know about response modification of therapy delivery. It's the fundamentals behind Qui's radar study, and I'm sure we will see a positive result for that. And also, fitness is looking to try and drive forward our decision-making based on patient physicality. So another shameless plug, this is Charlotte Paula and I's iFit, which is funded and should start, well, about debate. We would like it to start Q2, but probably Q3 next year. But what this is going to do is take the answers from radar, which we expect, and the answers from fitness, and drive a decision-making tree. We're going to basically look at people after 6 cycles of DRD for their response and their frailty. And people who remain frail will follow this IFIT2 arm if they're MRD positive. Everyone who's MRD negative goes into this, which is looking about de-escalation of therapy. But if you remain MRD positive and frail, at the moment, that's what we're looking to do for them. And if you are not frail, then we're looking to see whether immunotherapy with combinational T-cell engagers could drive that MRD negativity. Depending on safety data which we're awaiting, there may well actually be a way that we can bring a T-cell engager in there and a very modified dose and drug delivery, but that's for discussion at a later date. It's funded by a cooperative grant from J&J Innovative Medicines and CRUK, as I say, coming to a centre in the EU next year. So potentially, could we add in some functional enhancement in this, depending on what we see with the senolytic therapies, see what we see with exercise programming? We might be able to make more people follow that line if they're MRD positive, and that would be very useful going forward. So, my thoughts. We do have an optimal frontline treatment in myeloma now, the best we've ever had in the transplant non-eligible population. Doesn't mean that we can't do better. One size does not fit all. Being transplant non-eligible is a heterogeneous group, so we do need to look about how we personalise our decision-making for such patients. Now, is that going to be a geriatric assessment-based approach alone, or is it going to involve biomarkers, including radiomics? That time will tell. But if you incorporate the host response biology with tumour genomics, then I think we will get to a position of personalised medicine. This is my research group. I'd like to give a shout out to them for all the work they've done. Matt Clark is the clinical, he's a radiographer, PhD student of mine, who's doing the radiomics hypersegmentation. Chris Winder is the AI guy, there's Chris at the front here, who's doing the algorithmic work in this setting. Zoe just joined our group as a PhD in immunology, and she's doing the work with mitochondrial investigations. And with that, thank you for your attention.